Welcome to this WFH medical plenary dealing with diagnosis. We're fortunate to have two very distinguished speakers in this plenary session. The first presentation will be given by Professor Alok Srivastava, who's Professor of Medicine at the Christian Medical College in Vellore, India. He'll be discussing diagnosis of haemophilia. Is a new paradigm needed? And I imagine a good deal of Professor Srivastava's recent time, a good deal of that time will have been spent coordinating efforts by World Federation of Haemophilia in updating in a comprehensive way their document on guidelines for management and diagnosis of haemophilia. So I think he's very well placed to discuss this topic. After that, the second presentation will be given by Pierre Toulon, who's Associate Professor of Hematology in Nice. He will be discussing a point of care diagnosis for haemophilia, diagnosis outside of the conventional laboratory setting. And this is an important area for the World Federation of Haemophilia, particularly following Alain Wei's call to arms to those of us working in diagnosis to try and improve this situation and aim to facilitate a diagnosis out in the community.
Thank you, Dr. Kitchen, and greetings everyone. It is indeed a great privilege and honor to be presenting this plenary lecture in the WFH Virtual Summit on the diagnosis of hemophilia and other inherited bleeding disorders. Is a new paradigm needed? Indeed, this is a subject that has been of interest to our community for a long time, and I'm grateful to the scientific committee for the opportunity to talk about it. I'd like to mention that I have received research support as well as served on the advisory and grants review committees of several pharmaceuticals. My lecture today would consist of 4 parts, starting with a description of the extent of underdiagnosis, moving on then to a description of the current diagnostic model and whether it has failed to achieve its goals. I'll then go on to address ways in which these challenges may be overcome, and finally present a new paradigm for the diagnosis of inherited bleeding disorders. So what then is the extent of underdiagnosis? What this slide shows you is the data from the 2017 WFH Annual Global Survey, when about 315,000 people with inherited bleeding disorders were documented, about 200,000 of whom had hemophilia. This would account for less than 25% of the expected number on the presumption of about 10 people with hemophilia per 100,000 population, and of course no clarity on the distribution of severity among this number. A closer look at the data would show that nearly 100% of people with severe disease have been identified in the high-income countries, while anywhere from 5 to 50% of people with severe disease have been identified in the low and middle-income countries, the overall being somewhere in the 20 to 30% range. A very interesting study was published last year on the prevalence of hemophilia at birth. Data was collected from well-established registries in 3 countries, Canada, France, and the United Kingdom, and what they showed was that the prevalence at birth of both hemophilia A and B ranged between 25 to 30 per 100,000 male births, which was almost 25 to 50% higher than the earlier presumption of about 20 per 100,000 male births. If this data can be extrapolated to the entire world, then what you will find is that the extent of underdiagnosis becomes even greater. If we apply these estimates to the numbers collected in 2017 in the Annual Global Survey, the approximately 200,000 people who made up about 25% of the expected number of about 800,000 by those estimates, would now become less than 20% of the total, with a new estimate of more than 1 million people with hemophilia in the world. In fact, just a few days ago, a longitudinal profile of the data collected through the annual global survey of the number of people with hemophilia identified in the world has been published. In 1999, about 78,000 people with hemophilia had been identified. This increased dramatically to 210,000 people in 2018, a change of almost 204% during this period. While this is certainly very important and significant, if you look at it in another way, the identification rate changed from around 12% in 1999 to 26% in 2018. Now, at this rate, even in the next 50 years, we may not be able to identify all the expected people with hemophilia in the world. And that would certainly be disappointing. What this slide shows you is data extracted from the Annual Global Survey 2018. It is a busy slide with a lot of numbers, but I'd like you to concentrate on the middle two columns, which shows you the number of people with hemophilia documented in these countries, most of which have more than 100 million population, and the approximate percentage of the total number that these make up. Starting with the numbers in green, what you find are two countries in Africa with more than 100 million population, where only 2 or 3% of the expected number have been detected. We then move on to the numbers in black, which are most of the countries with large populations in the low and middle income group, where between 10 and 60% of the total number have been detected. You will find that the two countries with more than 1 billion population, China and India, have detected only 14 to 15% of the total expected number. The countries shown in blue here are two high-income countries, Japan and the United States, where only about 50 to 55% of the expected number have been found. What is remarkable, shown in red, are the three countries with very good registries, Canada, France and the United Kingdom, where more than 100% of the expected number have been detected. So what this shows us is that the detection and diagnosis of people with hemophilia and inherited bleeding disorders are indeed multifactorial, and there could be many reasons for the low numbers which need to be addressed. So what all these data show us is that even after 3 to 4 decades of massive efforts to diagnose hemophilia and other inherited bleeding disorders, more than 75% of the expected number remain undiagnosed. Should this model not be considered a failed paradigm? I'll leave it to you to think about that answer. So what exactly is the current diagnostic model? What this slide shows you is the current approach to the diagnosis of inherited bleeding disorders. When a child with suspicion of excessive bleeding presents to the family or primary physician, a clinical assessment is made of the bleeding history and the physical examination, and based on that, this child may be referred to a center where the screening tests and other common hemostasis tests will be performed. If these are found to be abnormal, then this child would be referred to a higher center where confirmatory tests such as factor assays or platelet function tests will then be performed to confirm the diagnosis. Now this may then stop at this point and the family will be counseled, treatment offered, or it may then go on to a referral to another center where genetic evaluation may also be done. Now this, as you can see, has several challenges. At every stage there needs to be a referral, an appointment, a travel by the family with all the loss of time and resources required for it, and in many countries with poorly developed health infrastructure, the required tests both at the screening level as well as the confirmatory level may not be available. The result is days, weeks, months, or sometimes even years of delay in diagnosis. and this really explains why we have such low detection rates of hemophilia and other inherited bleeding disorders in the world. What I've just described was the conventional approach. Shown on this slide are some recent recommendations or plans for assessment of people with suspected bleeding disorders. The one on the left is from a review article, and the one on the right is from a Dutch-Canadian proposal for prospective evaluation of patients with suspected bleeding disorders. Both have a lot of small font recommendations, and so I have extracted the core messages. Both now want to recommend or plan to use bleeding assessment tools to document clinical bleeding in a standardized way and follow it up with evaluation through tests of hemostasis, and then go on to genetic assessment as part of the standard evaluation. While this could work well in Western Europe and parts of North America, it will throw up all the challenges of the lack of suitable hemostasis labs in most of the low and middle income countries of the world. So while the inclusion of bleeding assessment tools for standardization of clinical assessment of bleeding and replacing them with even self-assessed bleeding assessment tools are a welcome modification that could be easily adopted around the world, the continued emphasis on clot-based assays and platelet function tests would keep this approach impractical in many parts of the world. All the challenges mentioned earlier of the difficulties in establishing and standardizing these tests in hemostasis labs will continue to challenge the diagnosis of inherited bleeding disorders in many parts of the world. External quality assessment is an important aspect of quality assurance. There are hardly any examples of such schemes operating from low and middle income countries independently. With help from the UK NICWAS, indeed Drs. Eric Preston and Steve Kitchen himself, in the late 1990s, we established a national self-sustaining program where we even manufacture the lyophilized samples ourselves more than 15 years ago. What this data shows you is that with more than 1,000 labs participating, we have less than 100 that can perform factor assays, and most of these are limited to a few big cities. There are whole states, like countries in other parts of the world, with no laboratories which can perform factor assays or do platelet function tests. Patients in these states do not therefore have access to the full complement of hemostasis diagnosis. And among the ones which do, from a quarter to third have results which are often out of range for different assays. Therefore, the reliability of such evaluation becomes questionable. So how can we overcome the challenges that exist in the diagnosis of hemophilia and inherited bleeding disorders? I think there are two parts to it. We need to create a new paradigm where we simplify and standardize clinical assessment. This could be fairly easily achieved, as mentioned earlier, with the use of bleeding assessment tools, and even more so by using the self-assessed bleeding assessment tools. We will discuss this in a little more detail in the next slide. But more importantly, towards laboratory assessment, we need to move to a system where the huge pre-analytical, analytical and post-analytical factors which have dogged hemostasis tests for decades need to be reduced. We need systems where these are less consequential or are easily addressed by the methodology itself. How really can we achieve that? There are two sets of possibilities. One is the use of point-of-care devices, and the other is to move to genetic testing as an earlier step in the evaluation of people with these disorders. Of course, they would definitely require subsequent confirmation by functional hemostasis tests. Bleeding assessment tools have been in use for more than 15 years. Initially designed to quantify and differentiate mild bleeders such as type 1 von Willebrand disease from normal people, it has now been applied to the full range of bleeding disorders, including the rare bleeding disorders and platelet function disorders. In fact, there is limited data available on its use in quantifying bleeding in different severities of hemophilia as well. As shown in the lower figure in this slide, those with severe hemophilia have a higher BAT score than those with moderate or mild disease. What is shown in the upper left figure is the range of normal values among children which is gender independent. Normal ranges have also been established for adult males and females. There has been an effort at moving towards self-assessed BATs, and very recently, late last year, there was an interesting paper published from the Utrecht group showing that an electronic self-assessed BAT has good correlation with the ISTH BAT. This shows that patients or parents could sit at home and send in their BAT scores. So with a good possibility now of simplifying and standardizing clinical assessment using bleeding assessment tools not only in the hospital environment but also from the home setting, what can we do about laboratory evaluation of bleeding? Let's first look at the possibility of using point of care testing devices. The first point of care device that I would like to mention is the clot chip. This has been developed by scientists at the Case Western Reserve University, Cleveland, Ohio. It consists of a microfluidic system using a dielectric microcenter whose impedance changes with hemostasis in whole blood dielectric permittivity. The details of this method involve more physics than would be easily understandable for most physicians. However, the good thing is that it's a disposable device which requires about 10 microliters of citrated whole blood warmed at 37 degrees. The warming makes it difficult to use in field conditions and would need to be done in a laboratory. In a recent publication, they have shown good correlation with ROTEM and thrombin generation assays in people with hemophilia with and without inhibitors receiving replacement therapy. The second device that I'd like to talk about is the NGPad. Initially developed by investigators at the Radboud University Medical Center, it is now being promoted by a company called Enzyme. The NGPad uses sub-microliter volumes of blood with chemiluminescence technology in combination with high-performance nano-optical sensors. It is claimed that its readouts correlate with chromogenic assays and ROTEM data, but publications are still awaited. It requires less than a microliter of blood for doing multiple measurements, but which seem more directed at monitoring therapy than primary diagnosis, which may not be the focus for the markets for which it is being developed. The third and final device that I would like to talk about is the lateral flow immunoassay based disposable device being developed by the National Institute of Immunohematology, a unit of the Indian Council of Medical Research based at Mumbai in India. In this device, antibody conjugated gold nanoparticles are placed in membranes which allow lateral flow of blood for an immunoassay based detection of the deficient factor. Currently developed for the diagnosis of severe or moderate hemophilia with factor levels less than 5% or severe von Willebrand disease with von Willebrand antigen being less than 3%. It may also be applied for detection of other deficiencies depending on the antibody used in the matrix. It is intended to cost less than $1 per device. So what can we make out of these point of care devices? What is clear is that multiple options are evolving with full details not being available for any. While 2 of them are currently directed at monitoring therapy through quantitative assessment of specific factors, one is directed at diagnosis of factor deficiency in a semi-quantitative manner. With further modifications, it is possible that these devices could supplement BAT assessment in the field to reach presumptive diagnosis till full hemostasis evaluation is possible. Certainly, they hold promise. So what about genetic testing approaches to the diagnosis of inherited bleeding disorders? The conventional approach to genetic diagnosis of the inherited bleeding disorders started with linkage analysis, which then progressed to specific mutation detection, at least for the common mutations such as the inversions. It then moved to screening the factor VIII and IX genes for sequence variations, followed by Sanger sequencing of the relevant regions for identifying the mutations, while other techniques were applied for the detection of large deletions. Finally, with improving technology and automation, whole gene sequencing became easier and faster, even though more expensive. From a clinical perspective, index case evaluation was the major indication for genetic analysis so that carrier detection and prenatal diagnosis services could be offered. Otherwise, genetic evaluation remained mostly in the realm of research applications. But everything changed with access to next generation sequencing techniques, with increasing sophistication of the platforms available, where instead of single genes, whole panels of genes, now going into thousands, could be simultaneously sequenced, leading to very complex data sets, which then needed special bioinformatics platforms to analyze. But that opened up new vistas in the assessment of bleeding disorders, particularly the ones for which there were no easy functional hemostasis assays. What is shown here is one of the early large series reported from the UK, where a set of 300 samples were analyzed. There were 4 categories: those with known pathogenic variants, those with etiology suspected, those with no suspected etiology or affected with uncertain cause, and then some unaffected relatives. What is important to note is that among those with known pathogenic variants, 100% mutation detection could be achieved by the NGS technology. And in those where clear etiology was suspected, more than 90% could be identified through this technology. Next, I want to draw your attention to the large-scale effort for an advanced NGS-based approach in USA to genotype all people with hemophilia. The beauty of this approach is in the adaptation of the method to detect inversions as well, which makes it most useful for analyzing all severe factor VIII deficiency cases where inversion 22 and inversion 1 would account for nearly 50% of all cases. This was achieved by designing specific probes to account for these large inversions. Using this approach, causative mutations were identified in more than 98% of hemophilia A and more than 99% of hemophilia B patients, showing the robustness of this approach for the detection of the full range of hemophilia mutations. This slide shows the spectrum of inherited bleeding disorders which are seen annually at our institution in southern India, which has about 10% consanguinity in the community. Given that we cater to a large population of nearly 250 million people in the southern states, these numbers are not surprising. Please note that after hemophilia A and B and von Willebrand disease, it is Glanzmann's thrombasthenia that is the next most common inherited bleeding disorder in our population. Over the years, we have gone through the full spectrum of methods for genetic diagnosis and mutation detection in these conditions, and over the last 3 years we have started applying the next-gen sequencing platform not just for hemostasis disorders but for a whole range of hematological diseases. More than 3,000 samples have been analyzed and more than 1,500 families have been offered genetic counseling services during this period. We then wanted to see how NGS will work in our hands for the diagnosis of hemophilia and von Willebrand disease. We therefore identified all samples in the lab for which we had already completed genetic analysis by conventional methods. We then administered the ISTH pad or self-pad to these patients and correlated the abnormal scores with the mutations detected by NGS. What we found was quite interesting. Among people with severe hemophilia, regardless of the BAT score, NGS found mutations in all 100%. More than 90% of people with moderate hemophilia and about 80% of those with mild disease. In samples from patients with type 3 von Willebrand disease, causative mutations could be found in about 80 to 85%. This analysis was done with approximately 5,000 gene panel in which there were 91 hemostasis related genes. What's also very important to note is that we could offer these tests for less than $100 cost of reagents. So what then could be a possible new paradigm for the diagnosis of hemophilia and inherited bleeding disorders? I hope that you are convinced that transformational change in the diagnosis of inherited bleeding disorders is unlikely with the conventional hemostasis test approach. If we want to address the huge gap between the expected and actual numbers of people with hemophilia and other inherited bleeding disorders in many countries, then a new approach is needed. This is probably best achieved by standardizing clinical assessment through the use of BAT scores, or more importantly self-assessed BATs, and those found to have abnormal scores would then be subjected to an NGS panel based analysis for a range of bleeding disorders. It is very likely that a high percentage of those with known mutations or other specific causative variants would be identified. These would then need to be confirmed with specific hemostasis assays for their diagnosis. Of course, for such an approach to be implemented, much more work will need to be done on the applicability of BATs in different cultural, linguistic, and socio-economic backgrounds. Deciding on suitable BAT score cutoffs to reduce the number of negative tests on NGS-based genetic analysis, choosing suitable gene panels for working out a cost-effective model, and having either improved point-of-care devices or establishing central hemostasis labs to perform the functional studies required for confirmation of diagnosis and severity. And finally, increasing awareness among healthcare professionals and patients' families towards such an approach. So what will be the impact of such a paradigm? What is very likely is a rapid increase in the number of people with hemophilia and other inherited bleeding disorders. In fact, if found successful, then such an approach could be integrated into the community health plan through various child health schemes, prospectively screening for bleeding disorders rather than waiting for these children to present with complications. A model could be established for the diagnosis of inherited bleeding disorders, which is not limited by local manpower expertise or technology, because these samples could then be sent anywhere in the world for analysis. Functional confirmation may continue to be a challenge unless point-of-care devices suited for such purposes become widely available. And of course, appropriated resources will need to be found for treating large numbers of these patients with various inherited bleeding disorders. But that may be a good problem to have to resolve compared to decades of lamenting the lack of diagnosis. And with that, I'd like to thank you for your attention and hope that you are convinced that we require a new approach for the diagnosis of hemophilia and inherited bleeding disorders, and perhaps the best option available to us right now is the combination of self-assessed BAT with an NGS-based approach to mutation detection, followed by conventional hemostasis tests as best as possible to confirm the diagnosis. Not only will this increase the number of people with hemophilia, but also the rarer bleeding disorders, which at present are of course much more difficult to diagnose. Thank you.
Thank you, Mr. Chairman, for this kind introduction. Good morning, good afternoon, or good evening, everyone. I would like to thank the organizers for inviting me to have this lecture about point-of-care diagnosis of hemophilia. Here are my disclosures and the agenda of this talk. We will make a short review of point-of-care hemostasis testing in 2020, and then we will go more in depth in the point-of-care diagnosis of hemophilia. So today, indications of point-of-care hemostasis are mainly related to the monitoring of anti-thrombotic treatments with unfractionated heparin during extracorporeal circulation, ECMO, for instance, using the ACTs, activated clotting time. It's about monitoring of treatments with vitamin K antagonists using the INR, including the self-measurement of INR with or without self-management of the treatments by the patients, and even INR measurement in remote institution without laboratories. We can also monitor antiplatelet drugs such as aspirin or P2Y12 antagonist using, for instance, the Verify Now device. The other indication is related to blood product management during hemorrhagic surgery using viscoelastometry as a test result from TEG or ROTEM or even from PTA-PTT could drive the transfusion of blood products. So what about point-of-care diagnosis of hemophilia, and why consider point-of-care or precisely out of the laboratory diagnosis of hemophilia? Because as you can see from this slide, obtained from the WFH Global Survey 2018, there are a huge number of countries, mainly from Africa, Southeast Asia, and South America, who did not report many cases of hemophilia and other bleeding disorders due to different factors. The first one is some of the countries did not belong to the WFH at the time of the survey, and the other is an under-diagnosis of the disease. And this is more clearly depicted in that slide. I would like to thank Sayou Diop from Dakar, Senegal for it. And as you can see, in Africa, there are only 11.4 cases identified. The same applied for Southeast Asia, and it's totally different from what we know from America, Eastern Mediterranean, and Europe. So there is a gross underdiagnosis of people with hemophilia in some countries, particularly in Africa and Southeast Asia. It was the reason why during the last WFH World Congress in Glasgow 2018, Alain Veil, our president, issued two strong calls to action, and the first one was to acknowledge the urgent need to develop a diagnosis device that is reliable, easy to use, and affordable. And he concluded stating that hemophilia needs something as simple as a skin prick test for glucose monitoring. However, there is a big issue because glucose is far less complex than the coagulation cascade. It is a simple organic molecule, and its measurement is much more easier than the measurement of the coagulation and even the measurement of specific factor like factor 8 and factor 9, because there are many interrelationships between other clotting with other clotting factors. So there are three main options identified today to perform out of the lab diagnosis of hemophilia. First one is to use screening assays such as the APTT. The second one was to use semi-quantitative assays for factor 8. At the moment, it's only available for factor 8. And the last one was to use quantitative assays for factor 8 and 9. So what about APTT as a point-of-care screening assay for factor 8 and 9 deficiency? As you remember from the coagulation cascade, there are two different pathways: extrinsic pathway, which is evaluated using the PT, and the intrinsic pathway evaluated using the APTT. And APTT, the activated partial thromboplastin time, is sensitive to factor 8 and factor 9 deficiencies, but also to other coagulation defects like factor 11 deficiency, factor 12 deficiency, contact phase deficiency, and also abnormality related to the common pathway. And in addition, the APTT is also sensitive to an acquired abnormality such as lupus anticoagulant, which is never associated with any bleeding tendency. So it's a global assay. How to perform point-of-care measurement of APTT? There are two devices available today. The first one is a CoaguCheck Pro 2 from Roche. This device is able to perform PT-INR and APTT measurement on the capillary blood using specific cartridges. It's a soft cartridge. You insert it at the bottom of the device. You pick a drop of blood using this purple device. You drop it on the slide, and then you let the blood flow along the strip, and you read the results within minutes. The second device is the Hemochron Signature Elite from Werfen. Same principle. In that case, it's hard slides. You insert this slide on the right part of the device. You put a drop of blood in the well, and you let it flow along the two capillary, one for the control purpose and one for the test, and you obtain the result here. It's able to perform ACT, we discussed earlier, and APTT, both on capillary blood and on saturated blood using specific cartridges. There are other point-of-care hemostasis devices available today, but no cartridges for APTT are available for them. So what are the advantages of using APTT as a global screening assay for factor 8 and 9? The main one is that it's already available either for capillary blood or saturated blood. It's affordable with a list price or below €7 per test, but you can negotiate it, I suppose. There are potential limitations, and the first one and main one is that it's a global assay. It's not specific for factor 8 and factor 9 deficiency. It's also sensitive to other clotting factor deficiency, not associated with bleeding tendency, such as factor 12 deficiency, but also to lupus anticoagulant and acquired coagulation abnormality, never associated with any bleeding complication. There is a need for specific measurement of factor 8 and 9 in the case of a prolonged test result. So it's a two-step diagnosis strategy. And what is the sensitivity to low levels of factor 8 and 9? Because we don't know so far, because these devices were not developed in that indication. And last, what is the stability of the test strips to high temperature and humidity? Because as you remember, most of these countries are located between the two tropics. So what about the semi-quantitative assay for factor 8? At this point, there is only one device which will be available in the near future for field study. It's a rapid point-of-care test for diagnosis of hemophilia and also for von Willebrand disease. This device was developed by Dr. Shetty from Mumbai, India, and I would like to thank him for sharing with us this data. Briefly, this assay is a rapid semi-quantitative solid phase immunochromatography assay for factor VIII. The factor VIII specific antibody is conjugated with colloidal gold and applied to an acetylcellulose chromatography membrane housed in a single-use plastic device, such as those used for instance, pregnancy test. And briefly, 50 microliter of plasma sample is dispensed in the well of the plastic device, and the factor VIII antigen present in the sample will react with the immobilized gold conjugated specific antibody. After allowing plasma to be adsorbed on the membrane, we perform a chromatographic migration using calibrated drops of buffer dispensed in the same well, and the factor VIII antibody complexes will flow along the strip in the aqueous phase until captured by a second antibody directed against factor VIII, located in the test zone marked T on the device, and the factor VIII concentration above around 5 international units per deciliter, which means 5% factor VIII, will cause the formation of a colored line indicating a positive test result. Excess of uncaptured gold conjugated antibody will continue to flow up the strip until it is bound to a marine-specific antibody immobilized in the C zone, the control zone, marked C on the device. So you need to have this bound for validating the test. They perform some kind of sensitivity specificity evaluation of this device. As you can see on the upper part of this slide, that they evaluated dilutions of normal pool plasma. It's a normal pool plasma, 1 to 2 dilution, 1 to 4, and so forth. And as you can see, until 1 into 32, the band in the test zone is detectable and not in the further dilutions. Control experiments were performed using plasma from type 3 Willebrand patient. And as you can see, there is no band detectable. And in this case, the factor VIII concentration is around 2.3%. They also perform control experiment using a normal plasma, plasma from factor 7 deficient patient and hemophilia B patient. As you can see, the band is present in all cases. There could be some kind of semi-quantitative estimation of the factor, as you can see here in the bottom of this slide. Until 6% factor VIII, there is a band detectable, not in for first lower concentrations. So it's possible to read and to integrate this profile using a reader. Here, example of normal plasma, severe factor VIII deficient patient, mild factor VIII deficient patient, and they develop also a strip for the diagnosis of severe von Willebrand disease, type 3. And in that case, they use a polyclonal anti-von Willebrand antibody. And one of the main advantage of this device is that the expected production cost of these strips is below 15 Indian rupees per strip, around 0.7 US They also perform local evaluation of these factor VIII strips and von Willebrand strip in 300 samples from patients with a bleeding history. As you can see, the accuracy rate of these strips as a screening test when compared to lab-based assays was 94% for factor VIII strip and 99% for von Willebrand strip. So it's simple, rapid, and cost-effective post-hoc device, which was developed for the diagnosis of moderate and severe hemophilia A, as well as type 3 von Willebrand disease using another antibody. It allowed a rapid visualization of the bands generated within 10 minutes after the application of the plasma sample. Standardization had been done to detect all clinically significant bleeders below 5 international units per deciliter for factor 8 and or for factor vibrant. There could be some kind of quantitation using reader, and only 50 microliter of plasma is required for the diagnosis. It's one of the limitations because it's not possible to work using whole blood. So advantages already developed. The prototypes will soon be available for field study due to the COVID-19 pandemic. We were not able to perform this field study before. It's affordable. Expected production costs less than $1 US. However, there are potential limitations. The first one is an antigenic assay, not an activity assay, so it could be some issue with CRM positive patients. It's a semi-quantitative assay, even if some kind of quantitation is possible with a reader, but due to the lack of sensitivity in the low range of factor 8 concentration, below 5%, 5 international units per deciliter, there is a need for a precise laboratory measurement of factor 8 in the case of a negative result to discriminate between severe and moderate hemophilia. It's not available for factor 9 measurement so far. And what is the stability of the strips to high temperature and humidity? I don't know. So let's go to the quantitative assay for factor 8 and factor 9. As you remember from the lab-based assays, there are two options to measure factor 8 and factor 9. The first one is to measure antigen concentration, and the other one was to measure activity of the clotting factors. So activity assays are usually performed using one-stage clotting assay, but also using chromogenic substrate-based assays, which are more and more used in the laboratory due to the introduction of extended half-life products, which react surprisingly with the one-stage clotting assay. Other possibilities to use two-stage clotting assays, but this kind of assay is difficult to automatize on modern coagulometers. And the other option would be to use fluorogenic assay, not used in the labs, but this option was taken by the developers of point-of-care assays. There are two prototypes or proof of concept developed by Enzyre or AirElse today. The Enzyre point-of-care device for factor 8 measurement consisted of 3 different parts. The first part is to collect a drop of blood. You put this device on the card. It's a disposable cartridge containing test-specific reagents, and you insert the cards into a pad, which is a reusable processor able to interpret the signals. The reagents present in the card could allow the measurement of 12 different enzymatic reactions at the same time. And the test results are transferred to your mobile phone through Bluetooth connection. So the concept is based on microfluidics, biochips, and fluorogenic detection. It is expected to perform factor 9, factor 8 measurement at least, but also 10A generation, 2A generation, and plasmid generation, and other measurement which will be developed. And at the same time, we could, it is expected to perform 12 different enzymatic reactions. The calibration curve is linear between 0.3 and 100%. And the correlation with chromogenic factor 8 assay pretty good in the plasma from patients treated with standard factor 8 concentrates. So the advantage of this device, it requires a small volume of blood, around 10 microliter, which enable us to simultaneously measure up to 12 enzymatic reactions with a high sensitivity and specificity. Potential limitation, it's not already available, it's in development today. The cost, it's expected to be between 20 and 50 US dollar per strip. The storage conditions are unknown because we don't know the sensitivity of the device and the strips to high temperature and humidity, and it's quite complex because it's a microfluidic based assay. The other device was developed by Health. It's based on the same principle. You collect a drop of blood, you insert it in the device, and you let the blood flow along the capillary and until a reaction chamber where the laser excitation light is transmitted, and you collect the results at using a reader. Advantage, below 10 microliter of whole blood, quantitative assay in the range of 1 to 200% factor 8, time to result below 15 minutes, and the cartridge was evaluated to temperature up to 45 degrees Celsius, so pretty good, but we don't know about the influence of humidity on this device. The calibration curve is not linear in that case, it's polynomial, and it's accurate between 0.4 and 200% factor 8. What is very interesting with this device is the high precision of the technique in the low range of concentration with coefficient of variation between 2 and 4%, with concentration below 13 international unit per deciliter of factor 8, which is far better than what we know from the lab-based assay. The calibration correlation with factor 8 is pretty good, using factor 8 deficient whole blood spiked with NGS-based factor 8 standard, and also using samples from patients. Advantage, small volume of blood, below 10 microliter. The prototype is already developed with a good correlation with chromogenic assay. The cost is quite the same. It's expected to be between 20 and 50 US dollar, depending on the volume. What is the sensitivity to high humidity and still the complexity? Concerning the POC, quantitative POC assay for factor 8, advantages is a promising tool for hemophilia diagnosis in remote area, and its specific assay for factor 8 and 9 activity, allowing an accurate diagnosis of hemophilia A and hemophilia B. However, there are some limitations. It's not already available. There is a 2 to 4 year development. Factor 8 assay is probably easier to develop than factor 9 assay. The cost is quite expensive, between 20 and 50 US dollar. It's quite complex. So in conclusion, out of the lab diagnosis of hemophilia, it's a promising tool for hemophilia diagnosis in remote area, but there is no silver bullet so far. The main technical issues today are the availability of the test, the cost in some kind, the stability of the device and our cartridges to high temperature and humidity, and the performance in real life. We don't know exactly. And we hope to have results to present during the next WFH World Congress in 2022. But after having overcome the different technical issues, there is a big issue: how to implement such a diagnosis strategy in resource-limited settings, alone or in combination with other diagnosis strategy like malaria or sickle cell disease. And this will raise some political issues. So I thank you very much for your attention.